It's a hard thing to be in Vail, Colorado on a beautiful afternoon like this. I probably appreciate it more than you do because it's so incredible just to come into a place like this. It's unbelievably beautiful, and it actually, to me at least, is not irrelevant to our topic tonight, which is the role of spirituality in health. Not any particular religion, not any particular belief system necessarily, but very much what Dan was talking about, this idea that, humans, we're not tabula rasa, we're not just blank slates. We come into the world, we're a species. We have certain things that really kind of define us universally. And I would suggest that one of those is a yearning for things that we call spiritual, a yearning for purpose, meaning, transcendence, a sense of something beyond just this sort of quotidian nature of a lot of what we have to deal with in life. And I have had a long-term commitment because of that to this interest in spirituality and health. And much of the work that we do with our colleagues at Emory, who are supporting some of the science up here, is looking at this question of how do we better understand the role of spirituality? Spirituality described that way, not as a particular belief system, but as a human yearning, almost, if you could put it that way. How do we understand how to optimize that for healthcare? Right? Because one of the great advances of the 20th century was seeing healthcare, it was seeing the human body and brain as a mechanism, as a machine. You don't necessarily want people to pray for you when you've ruptured your appendix. You want to know the doctor knows where it is. He goes, takes it out. Many, many things in our world have gotten incredibly better. Childhood mortality, death in childbirth. There's infections, amazing number of things that modern medicine has given us. But there's been a cost. And I would argue, and I think you'll hear some of this tonight, one of the costs is that there's a limit to that perspective of human beings as biologic machines only, because the soul is sort of lost from that. And we know, and you're going to hear tonight, there is overwhelming evidence that all of us, to various degrees, have that yearning for something we might call spiritual, that yearning for meaning and purpose. And if that's not included in healthcare, we're doing our patients a terrible disservice, but we're also missing a huge opportunity for leveraging things. And one of the studies that we're preparing to launch in this new Behavioral Health Innovation Center is a study looking at psilocybin as a novel treatment for depression. And one of the things that psychedelics, when they work and when they're done in this very careful clinical context, one of the things they do is they very often induce experiences that are clearly spiritual. And the more they do that, the more people get to sort of long-term benefit. So, we have this new ancient mechanism of psychedelics that are really driving this question of, wow, spirituality really can have these healing properties. How do we understand it? How do we understand its risks? How do we understand its benefits? So tonight's topic of spirituality and health is there's nothing in my mind that's more timely and, of course, to me, more interesting. So we are very fortunate tonight to have Doctors Tracy and Michael Balboni with us from Harvard to talk about this. They're just incredible world expertise tonight, so thank you guys for coming. I'll say that now. I'm going to introduce both of them. Dr. Tracy Balboni will talk first, and then Dr. Michael Balboni will talk second. So let me tell you a little bit about Dr. Tracy. She holds degrees from Stanford, Harvard Medical School, and the Harvard School of Public Health. She is a professor of radiation oncology at the Harvard Medical School and the program director for the Harvard Radiation Oncology Program. She developed and led the supportive and palliative radiation oncology service at Dana-Farber Brigham and Women's Cancer Center, a service that's famously dedicated to the needs of advanced cancer patients. She's also co-director of the Initiative on Health, Spirituality, and Religion at Harvard University. Her primary research interests are located at the intersection of spirituality and the practice of medicine, including the role of spirituality in illness, and you'll hear about that. And her work also includes forging improved dialogues between academic theology, spiritual communities, and the field of medicine. Dr. Michael Balboni is a congregational pastor and a theologian. He served as a congregational minister in Boston and an intentional Christian community of healthcare students and professionals. He holds a PhD in practical theology from Boston University, and along with Dr. Tracy Balboni, is a co-founder of the Harvard Initiative on Health, Religion, and Spirituality. He's published approximately 50 articles in peer-reviewed scientific journals on this topic. As a theologian, his focus has included the development of theology and spirituality in medicine, or of medicine. You'll hear about this. With Dr. Tracy Balboni, he's co-authored a really amazing book, Hostility to Hospitality, Spirituality and Professional Socialization in Medicine. He's also co-editor of Spirituality and Religion within the Culture of Medicines, working on a current book project, again co-authored with Dr. Tracy, entitled Dancing with Lois, focused on the 21st century church, the sick, and Jesus' call to healing. So, Dr. Tracy, I'll let you come up first.
Thank you. Great, thank you, Chuck, and thank you, Dan. Thank you to the McMunns and to all of you for your wonderful support of this endeavor and to supporting the health of this whole community. I've been so amazed just learning a little bit about it, about the work that you all are doing to invest in the health of your community, which is a beautiful place, but also needs investment in health. And it's just a privilege for me, for Michael, to be a part of those endeavors. In fact, I really think that doing that has a spirituality in and of itself, supporting and embracing the community around you by supporting its well-being. And certainly, Michael and I, coming from Boston, we live actually in the city of Boston. In fact, I walk to work every day. It's only 7 minutes away, so we live right next to the medical center. It's such a wonderful thing to come to. We just arrived yesterday. We've done 2 hikes and enjoyed your beautiful community here and the beautiful surroundings. And I can't say how just relieving it is to be, we're in the city in a very busy place. We hear ambulances all the time, which we've learned to tune out. But as you all, I'm sure, regularly experience, there's nothing like being in a place where you escape that and you experience connection with nature. And that, again, is a spirituality. I think we all recognize that. And it's funny that we all recognize that and know that, and yet when we think about health, we don't necessarily, in healthcare and health systems, we don't necessarily spend much time paying attention to that issue. And so that's what Michael and I are going to be addressing today. I'm going to be speaking about more from the empirical lens, a perspective on spirituality and health. I'm going to be focusing a bit more on my area of practice, which is on the care of people who are facing illness. But there's actually quite a robust amount of evidence on spirituality and population health. If we were doing that 2.5 hours with the test afterwards, we could include that, but we're not doing that today. I'm sure you're sighing in relief. So I'll focus a bit more on the research regarding ill populations, but say a little bit also about population health. And then Michael, I think it's important to consider an empirical lens. What is the research saying to us? But then I think there's also more of a social and theological lens that we can also take as we consider how we can begin, particularly how we can begin integrating spirituality into the practice of caring for the well-being and health of patients and communities. So as far as what I'm going to be doing today, I'm going to speak about some specific evidence regarding spirituality and serious illness, again, with a small amount of time spent on spirituality and population health, and then we'll speak about the implications for the practice of medicine, and then I'll turn it over to Michael to consider the socio-theological perspectives. So we're going to do this by, I'm going to tell you a story. This is actually a patient where some of the details have been changed only by including details from other patients, but just to give you a sense of how spirituality can interface with the experience of a serious illness. So this is a 57-year-old gentleman, Anthony. He's married. He has 2 young adult children, very successful businessman. He considers himself spiritual, not religious. He has some involvement in a faith community, particularly on holy days. And he actually had several months of blood in his stool, which he neglected to come to medical attention until it was quite severe. And when he presented, he was found to have metastatic colon cancer. He underwent many cancer therapies over the course of about 6 years. And even when it was clear that therapies weren't working and the metastatic cancer was bringing him close to the end of his life, he continued to pursue medical care. And this actually even created tensions in his relationship with his wife and adult children, something that they later even expressed to me and to others. The medical care was really minimally engaged with his faith, with his spirituality. He had a few visits with chaplains just during his surgical hospitalizations, and he had some supportive visits from his faith community, with the focus primarily being on prayers for healing, which is really what he wanted, was prayers for healing. He was asked near death by someone from his spiritual community about his own sort of preparation, but he really was not ready for that conversation and actually deferred it. And said he needed to focus on getting better. And he unfortunately died a few days later. And by the description of his wife, really this wasn't a good death. She had recent chemotherapy and many unmet spiritual needs, and it was also very, very difficult for her and for her children to experience this alongside him. So with this story in mind, we're now going to consider the empirical evidence regarding the interface of spirituality and the practice of medicine. And I'd say, just if I were going to summarize all of it, this is what we're seeing. We're seeing that in Anthony's care, he's a spiritual person. There are spiritual needs that are arising in the context of his illness. He has a faith community that he's somewhat connected to, and yet his health care is largely divorced from that. And care is largely based, his health care is largely based on wonderful, as was mentioned by Chuck just a moment ago, wonderful advances that actually allowed him to live quite a long time. He lived 6 years with his metastatic colon cancer. And yet there's something that was lacking, particularly towards the end of his life. I do want to take a moment and say here that spirituality, it's important that we all have different kind of ideas in our mind of what spirituality means, but it's important to take, as you can imagine, a very broad definition, because we need to encompass the myriad of beautiful expressions that spirituality can have across individuals and across communities. It's been defined by an international consensus conference on spirituality and health as a dynamic and intrinsic aspect of humanity. It's about seeking ultimate meaning, purpose, and transcendence, also relationship. And it's expressed generally through beliefs, values, traditions, and practices. So spirituality can have a sort of communal religious component, but it doesn't have to. It can be something that's much more of an individual component as well. So with that, let's turn to the evidence on spirituality in serious illness and health. So as part of a team of investigators, I was involved in this JAMA Special Communications report. This report came out of growing research on spirituality in illness and health, but with little uptake in healthcare, and largely because the research doesn't necessarily get into high-impact journals, and there's a bit of a bias about against the recognition of spirituality and health, as I mentioned to you a moment ago. But there's, fortunately, an increasing recognition of the role of spirituality as part of health. And I'd say it even goes back to the 1948 WHO definition of health, which specifically names that health is not merely the absence of disease or infirmity. It's much more. Of course, it names the physical, the mental, social well-being components. It doesn't say the spiritual, but actually in later definitions set forth by the WHO, they do name the spiritual. For example, the 2002 WHO definition of palliative care, which specifically names those components of health as including the spiritual. So this project was to provide a comprehensive assessment of the best, most well-done literature regarding spirituality and health for both ill and healthy populations, and then to name the implications of that evidence for the practice of medicine, both in serious illness and in population health, and that was done by an expert panel. So the way this was done was with a systematic review. I won't be taking you through the details of this. This is just to show you the process by which you go. This is a review that began in the year 2000 and went up until 2022. Over 13,000 articles were reviewed initially. There was a follow-up that included over 15,000. But again, this was digested down to the best and most robust articles, and the total that came out of sort of that sifting process were 441. There was a very similar process on health outcomes with 276 total articles from that review. So what were the results? So now looking at the best evidence over 20 plus years of data. So within spirituality and serious illness, there were a number of findings very particular to patients, and I think we even see this in the story I told you about Anthony. So first, religion or spirituality are important to patients, most patients with serious illness. We see that in Anthony's case. Spiritual needs are common. Again, we see that. Spiritual care within medical care is frequently desired by seriously ill patients. No one ever asked if that was the case for Anthony. I think his wife would say yes. But it wasn't a specific question asked of him. Religion, spirituality can play a role in medical decision-making for patients. I think we see that in the case of Anthony. And then unaddressed spiritual needs are associated with poor patient quality of life outcomes. Again, something we also see in this story. The rest of the findings were in regard to the health systems themselves. So spiritual needs are frequently unaddressed by healthcare systems in the case of seriously ill patients. Spiritual care is infrequent in the medical care of patients with serious illness, and then provision of spiritual care, so when it's present to patients with serious illness, is associated with better end-of-life outcomes, such as quality of life and the types of care that patients are receiving. So I'm just going to take you through some of the findings. So this was like an overview of the literature and sort of the main findings of that literature, just to, digested for you. But I'm going to take you through a few example studies just to give you a sense of what those overall findings are coming from. So, and they really address questions, which I posed to you here. So is spirituality important within illness? This is a national study of cancer survivors within the US, where they asked cancer survivors, my faith or spirituality has helped me through my cancer experience. And you can see quite a bit, or very much, it's about 70% of the entire population, with it being particularly important for certain racial and ethnic minority groups within the United States. And just following up on this further, this is a study done in the Boston area at 4 Boston centers. Again, 78% of these patients saying that religion or spirituality was important to their advanced cancer experience. They were then asked, those that said that were important were asked, well, how? How has it been important to your cancer experience? And their answers were recorded and then transcribed and qualitatively analyzed. And these were the themes that arose. So coping through one's spirituality was very common. This patient saying, if it weren't for my faith, I don't know if I would have kept my equilibrium through this process. Or spiritual practices, like this patient naming prayer, or beliefs that are framing one's sort of understanding of one's illness. Another theme being spiritual transformation, so an actual change in one's sort of spirituality coming about as a result of the experience of an illness. And then finally, the role of spiritual communities, oftentimes providing key support. So that's sort of the importance of spirituality in the setting of illness. What about the relationship of spirituality to patient quality of life, to patient well-being? This is a study of over 1,600 cancer patients, all stages of cancer, with spirituality measured with a validated scale called the FACIT-SP. And spirituality was found to be an independent predictor of patient quality of life, even after controlling for other key predictors of patient quality of life, suggesting it really is playing a key role in patient well-being. Another way of looking at this is, this was using sort of quality of life instruments and an instrument regarding spirituality. But what about just asking patients, what's most important to you? What's most important to your well-being when you're dealing with a serious illness? So this was a study of over 1,800 seriously ill patients, all types of serious illness. And they were provided with 44 attributes of what would be comprising their well-being at the end of life. And the top 9 of those 44 were ranked, and I'm just showing you the patient data here, being free from pain and being at peace with God. Of those 44, sort of tied for first. That's how the authors put it. So the most important factors for patients was this issue regarding being free from pain, and then also a spiritual issue, being at peace. As being named as one of the most important elements of one's well-being, even when facing a serious illness, facing the end of life. So a third question is what's spirituality's role in medical decision-making? This is a study which asked 100 patients with advanced lung cancers, their family, so the family caregiver coming to the appointments with the patient, as well as the oncologist caring for the patient, to rank 7 factors important to the patient's medical decision-making. So they all were sort of responding to what's sort of motivating the patient's decision-making regarding medical care. And these were the 7 factors, everything from the oncologist's treatment recommendation to patient's faith in God. And number 1 for all 3 groups, remember it's patient's family member, and then the oncologist. So all 3 agreed that the ability of the treatment to cure the disease was the number 1 factor, which of course I think we would assume that would be the high, if not the highest factor. But then next for patients and for their family members, and then last for physicians was patient's faith, patient's spirituality. So clearly this is something that's salient in patients' minds. The family knows that this is something that's in the patient's mind, but the oncologists caring for those patients don't understand that this is actually operating within a patient's decision-making. But does that actually impact the types of care that patients are receiving at the end of life? This study would suggest it does. So this is a prospective cohort study of patients across several centers in the United States where they assessed people at baseline, and one of the assessments was with religious coping. I mean, if you recall a moment ago, I showed you the qualitative study which showed you the themes. One of them was coping through one's spirituality. So they had a validated scale of that form of coping, which they did at baseline, and then they followed people to the end of their lives. And what you see on the x-axis here is types of sort of aggressive medical interventions in the last week of life. Now, mind you, all these patients, when they entered this study, had incurable cancers. And interestingly, so this was again at baseline, they divided patients into whether they were low religious coping patients, so they didn't score very highly on that form of coping, versus high religious coping. And the high religious coping is in the blue, and you can see those patients are receiving greater ventilation, greater resuscitation, and are more likely to die in the ICU setting. So it appears that yes, somehow spirituality is operating within medical decision-making. It's not clear how, but it's operating in a way, and it's actually patients are receiving greater aggressive care at the end of life. And of course that raises a number of questions, like why would that be the case? And this is one hypothesis. One is that there might be beliefs that are operating within the end-of-life setting that are actually influencing how patients are making decisions at the end of life. So this is a separate study done at multiple centers across the United States, all of advanced cancer patients. And they were asked to assess their degree of agreement with these sort of beliefs in end-of-life care. So just to give you one example, the first one, my belief in God relieves me of needing to think about future medical decisions, especially near the end of life. You can see the endorsement, any amount of endorsement is in the blue, and you can see that's the majority of patients. Or the third one from the bottom, I believe that God could perform a miracle in curing me of cancer. You can see that's the large majority of patients. So you can see that these beliefs are quite common, and in fact, 87%, so the vast majority, at least endorsed one of these items, and then 62% endorsed 3 or more items, multiple items. So just showing us that these sort of beliefs regarding end-of-life care are very operative in patients' minds as they're facing their medical decisions, and perhaps are influencing the types of care that patients are receiving at the end of life. So what about spiritual needs? We notice that in the story of Anthony, and this is a study done in New York City, so very racially and ethnically diverse. These were all cancer outpatients, all stages of cancer at 4 outpatient centers. Most of them were spiritual, not religious. And this was a validated scale assessing spiritual needs. So this was their scale, and you can just immediately see that across the various types of spiritual needs, most are experiencing, or nearly half are experiencing, some degree of spiritual needs. And at least one spiritual need was endorsed by nearly 80% of the patients. So frequent experiences of spiritual needs. So finally, a fifth question also addressed by this literature is, what is the relationship of spiritual care and outcomes in serious illness? If we begin to integrate attention to recognition of the role of spirituality in the setting of a serious illness, does that actually improve key things like patients' well-being or the types of care they're receiving at the end of life? And this study, a prospective cohort study done at multiple centers across the United States, addressed this together with other psychosocial factors and how they relate to end-of-life care. At baseline, when they entered the study, these were, again, advanced cancer patients, they were asked the degree to which their spiritual needs were supported by their entire medical team. They were also asked about supportive spiritual needs by spiritual communities, and they were also asked about receipt of pastoral care visits. The outcomes, which were assessed now prospectively at baseline, were quality of life in the last week of life, which was assessed by a caregiver present with the patient in the last week of life, and then medical care received in the last week. So this is the relationship of baseline reports of spiritual care being present as part of one's care and quality of life in the last week of life. The y-axis here is the measure of quality of life near death, and higher numbers mean higher or better quality of life. On our x-axis here, we can see this is various ways of looking at how patients reported the degree to which they were receiving spiritual care as part of their medical care. And I'm just going to draw our attention all the way over to the right. So here, the blue is when any form of spiritual care was present. And then the orangish yellow is when spiritual care was absent. And these are adjusted analyses, adjusted for baseline quality of life, adjusted for the types of care that patients were receiving. We see that when patients are reporting that spiritual care is integrated with their care, they have better quality of life at the end of life. Another question is, well, how does it relate to actual care, medical care received at the end of life? So high spiritual support from the medical team was infrequent, only 26% reporting it, but when it was present, patients transitioned to hospice more frequently, they got less aggressive interventions, and they were less likely to die in an ICU setting. And the impact of medical team spiritual support on end-of-life care was largely seen in those high religious coping patients. Remember a moment ago, I showed you how high religious coping patients tend to receive greater aggressive care at the end of life. It's when those patients had medical teams that recognized their spirituality, interfaced with them in that way, that they were less likely to receive greater aggressive care at the end of life. Interestingly, high support from religious communities was associated with less hospice, greater aggressive interventions, and more ICU deaths, and the findings were stronger among our high religious coping patients. And one wonders if it's maybe those, I showed you the, of course, these are all just hypotheses, but if maybe it's those religious beliefs in end-of-life care. For example, miracles. We saw in Anthony's story how the religious community came and prayed for his healing. And not that that's wrong, but one could argue that perhaps also there's a way in which medical systems can be better interfacing with religious communities, helping them to understand the medical realities in a way that helps them also to be talking about, yes, we want healing, but let's also have preparation, spiritual preparation, family preparation, et cetera, as part of providing spiritual care. So I said I would briefly touch on health outcomes in healthy populations. These are the list of them. I'm just going to diagram them out for you to make this simple. We're not going to go into the quantitative data today, but essentially the most robust data from large cohort studies following large populations of patients for long periods of time with control for confounding factors, et cetera. There's very strong evidence showing when patients are highly involved in spiritual communities, or what we might call communities of meaning, there is lower mortality, and even sort of a suggestion of the more you're involved, the more that it actually impacts your health with lower mortality. There's also, when one is involved in these communities of meaning, better quality of life and life satisfaction. There's less smoking, alcohol, and drug use among adolescents, less risky behaviors, including things like drug use. And then as far as mental health outcomes, less suicide, less depressive symptoms, and overall better mental health outcomes as well. So a number of very important sort of health findings as well when individuals are being supported by a spiritual community. Based on these findings, these are the implications named by that expert panel. So in regard to spirituality in serious illness, the recommendation was to be routinely incorporating spiritual care into the medical care of patients with serious illness, to include spiritual care education and the training of all members of the interdisciplinary team, and then to be including specialty practitioners of spiritual care, specifically chaplains, in the care of patients with serious illness. In regard to health outcomes, there's sort of similar, analogous recommendations that we should be incorporating patient-centered and evidence-based approaches that sort of take advantage of this fact that we see that communities are benefited by involvement, and individuals are benefited by involvement within spiritual communities that uphold their spiritual health. We need to be increasing education to public health professionals, and that spirituality should be recognized as a social factor that's associated with with health outcomes within public health education and other programs. So I just want to return to Anthony in light of these data. So, there's a number of things that are, problematic, or things that sort of, especially for me as a physician, but I'm sure for all of you, just even seeing this story that strike me. So first, he had months before he presented. Could he have presented at a time when his disease was curable? There was continued pursuit of care even when it was clear that he was dying, and this was creating tensions in his family relationships. His medical care minimally engaged his faith. He had support from his faith community, but it was primarily focused on healing. And not that that's wrong, it's right and good, but perhaps there could have been more, or there could have been ways that the medical system could have interfaced more so that his spiritual supporters could have a better sense of where he was in his illness trajectory. Of course, that resulted in him not being ready to talk about things, his own spiritual needs, and so spiritual needs remained unaddressed for him. Really with an impact not only on him, but also with on his family as well. So I think we have to ask ourselves, what could have been different here? What if his PCP had engaged him about his spirituality? Would that have built greater trust? In fact, there's data showing that when primary care physicians engage patients about their spirituality, there is greater trust and greater connection. Would that have somehow created a better connection that would have allowed him to even perhaps be screened earlier? I mean, maybe that's a stretch, but what about if the health system engaged with spiritual communities on cancer screenings, providing education on cancer screening, such that he would have been perhaps interfacing with education that would have helped him to have presented earlier? And then finally, what if the health system routinely incorporated spiritual care, integrated it with local communities in providing care to seriously ill persons like Anthony? How would that have transformed his experience, and how would that have transformed the experience of his family? So these are just a few questions we could ask, but I think they're questions worth asking and worth pursuing, especially the evidence that I've just showed you, I think, really highlights that. So yes, we're experiencing this. We see that in the story of Anthony, but I think the data is really pointing to the need to have an integration, a reintegration of spirituality with the practice of medical care. But to do that, we need to not only consider the empirical evidence, we need to consider other lenses as well. And with that, I'll turn it over to Michael.
It's wonderful to be with you. And Tracy is a tough act to follow. We've been married for 23 years. We learned early on in our marriage that she, working in the world of medicine, and I, working in the world of spirituality and religion, that these two worlds were totally separate. They had nothing to do with one another. The world of religion had nothing to say to science, and the world of science and medicine didn't want to have anything to do with religion or spirituality. And being married together, we began to realize, hold on a minute, these things actually have a lot to do with one another. And as we begin to look at patients, and as we've engaged the lives of patients in dealing with illness and serious illness, we begin to realize actually they have a lot to do with one another. Because when you get sick, you begin to ask existential questions about life, about purpose, about meaning, and about what's going to happen to me when I'm going to die. Because apparently, most research indicates that actually 100% of us are going to die. And we know it. And it raises all kinds of fear. And it raises all kinds of spiritual questions. The trouble is that the world of religion, particularly, does not speak much to the world of medicine, and the world of medicine does not want to engage the world of spirituality and religion. And that led us in this 2018 book that Tracy and I published, the very first sentence, to say that American medicine is spiritually sick. It's spiritually sick. Because what we know is that patient spirituality and religion is very important to most patients because of their dealing with these deep existential questions. They don't know what to do. We've dealt with many patients, and we know that. Whether they're deeply religious or they have nothing to do with religion, spiritual questions pop up, and they need people to engage. and the world of medicine generally is not engaging them. And we're also seeing at the same time that medicine itself, and I'll talk about this in a moment, is increasingly becoming impersonal. And there are systems and structures that are making it impersonal. And then we're also seeing across the United States that clinicians are experiencing less flourishing, less well-being, higher rates of burnout and of depression and of substance abuse, among other things. And many are leaving medicine because of the pressures and because it's become increasingly a dissatisfying sort of career because of the impersonal forces that are at play. One of the ways we can explore the impersonal kind of factors is just through the word of the use of language. And this is, you might have heard this, in which the patient is referred to as a case, and the clinician might be considered such as a scientist, the physician scientist. Hey, in room 101, our case needs X. It's a depersonalizing sort of language in which the human being is now referred to as an object to be studied, but is no longer being conceptualized by the very people who are taking care of him or her as a human being. This is becoming increasingly common, in which the clinicians within the hospital system are called providers. Heard that language? A provider. Oh, I'm a provider of medicine. And that language of provider is actually a commodification. It's a commodified understanding of what it means to be a healthcare professional. I'm providing something. I'm providing medicines, providing techniques, or whatever it might be in regards to health. This is a language it's an economic sort of framework and understanding what medicine is and what it means to be sick. And it's it's taking medicine and it's taking it, rather than from a scientific perspective, it's now making it into a buyer-seller sort of relationship in which one is providing something. Is the care of the sick, when you're sick or when you're being cared for by someone, is it primarily an economic relationship, or is it something else? Traditionally, over the last 2,000 years, those within most religious traditions, not just the Judeo-Christian, as well as in Islam, as well as in other religions, have recognized that the care of the sick is a responsibility that is neither primarily scientific, nor is it primarily financial. Those are important. But it is something else in which the patient, the traditional language, patient, which is the Latin for sufferer, is a person who is going through the dangerous journey of illness. Perhaps you've never been sick before, and they need someone they're a person who is suffering loss, and they need people to come alongside, possibly strangers, who understand the world of sickness and who can help them. And that's the language of hospitality. Hospitality in which you welcome a guest into your home. That's in the ancient world. That's what would happen. You go into a place that you don't know, and the people you did not know, they would, as host or hostess, they would bring you into your home. They would provide you a room. They would provide you food. That's hospitality. We know what hospitality is. But the world of medicine was framed around the language of hospitality, because you consider the language of hospital. What is a hospital? It's a place in which the sick who are on a dangerous journey are welcomed by strangers who have the powers to walk with them and to care for them during this difficulty. What's happened so that the world of medicine and the experience of healthcare has begun to change is that there are social forces that have been at play. And I would suggest to you that there are 4 primary social forces that have always been at play within American medicine for the last couple of centuries. We can begin with the legal and bureaucratic social force. This is the powers, there are invisible forces that people organize themselves around in organization, and it's the organization of power and how power is to be used on behalf of the sick. The second social force is science and technology. Of course, we know that, in which we learn and gain knowledge We do research to bring about new knowledge, and we produce technologies in which are used in order to care for the sick, to bring healing, to bring the alleviation of pain and suffering. And then finally, medicine is always required, has always been a market force. There's a business component to it. And one must consider the finances to pay all the bills. All three of these social forces are critical and important. They've always been part of medicine, but they are impersonal. They're not about the human person. They serve the human person, which is why I would suggest to you that the social force, I'll call it compassion or hospitality and compassion, which is the driving human energy to say that this sick person deserves my care, my attention, to look at them, to know their name, to walk with them through this very difficult thing that they're going through. And it's compassion. In the ancient world, in much of the modern world, that is not true. But particularly because of spiritual beliefs led our culture to believe that the sick deserve to be cared for by other human beings. It's a social energy. So these four social energies, they've always been at play. But up until about 100 years ago, it was compassion and hospitality that was the driving social force. And the other three impersonal social forces served hospitality and compassion. And over the last 100 years or so, these social forces, the impersonal social forces, have begun to grow. And the personal social force of hospitality and compassion has begun to decrease. And we've seen that these social forces, through all kinds of various decisions, have become stronger, larger, bigger, and hospitality and compassion has become still there, still a motivating power that is there, but it has been on the wane. And in some ways, we can see that among healthcare professionals, among health institutions, there's been an absorbing of some of these impersonal social forces in which those other motivations, external to the actual care of the human being who is sick and in his need, has been absorbed within the heart. So what do we do? Or why has this happened? Everyone would agree that compassion and hospitality are critical. And everyone, I think most people would agree that these impersonal social forces are there. And why are they there? And I would suggest to you is that because these invisible social forces are institutionalized by very visible structures of organizations and institutions. And the way the healthcare system is structured, I know it's a complex slide, but it takes the previous slide and it adds the institutions that embody the social force. And so every one of these social energies are taken on by different social forces. So the legal bureaucratic is taken up by Health and Human Services within the United States, or science and technology is taken up by the NIH or by pharmaceutical companies. Those organizations are motivated by that social force and they push it forward. Everything that they're doing is motivated around science and technology, but then there's also the financial, which is infused in some of these other social forces as well. And then there's certain organizations that are driven by the financials. For example, the insurance companies would be a good example. Medicare. It's all about the money, and that's important. So these institutions are driving forward the social forces. And they're all of this whole system is bound together. But then the question is, what institution is insisting on and has the mission of hospitality and compassion? You say, well, maybe the hospitals, but then the hospitals, of course, are also bound by these other social forces. You talk to a hospital president, like I was listening to a few months ago, and he had a compassion he had things that he wanted to use, but he had only a limited amount of money to put forward to a particular local need. He had all of these other obligations, and he had no way to change any of it. And if he tried to change it, he would get kicked out of his job and the hospital would shrink because the hospital is bound to these other financial, bureaucratic, legal, and technological forces. And so it becomes what Max Weber famously described more than 100 years ago an iron cage, in which this entire structure is linked together. And no matter how charismatic someone might be, no matter how intelligent, or even no matter how philanthropic you might be, you can't change the system. The system is being driven forward, and so that a patient like Anthony is being divided body and soul, so his individual needs aren't necessarily being fully cared for, particularly on the spiritual within the medical system. But Anthony is a symbol of the entire system, in which the spiritual and the religious, because there are no institutions that have been given the charge and have the power to insist on hospitality and compassion as being center and core, that we will do this, which is different than even 100 years ago. So what will it take to make medicine more personal? If you look at this diagram, this is a high-speed train, and it's on the fast track towards impersonal medicine. And everyone's pulling out their hair saying, what do we do? What do we do? What do we do? How do we change this? And if you look at the caregivers, these are the doctors, these are the nurses, these are truly, and most of them really are, compassionate, hospitable people who really want to care. They're all facing in the direction of the personal. That's why they went into medicine, to care for the sick. That's what really motivates them, but they are on this system train that is going in the opposite direction, and they can't stop it either. So many people are putting forward different kinds of solutions to address how patients are being decentered and how there's been this loss of human care. And what I've noticed is most of the solutions are coming from the social energies that have become rampant within American medicine. Science, technology, that can solve things. And so people put forward more scientific solutions in order to solve and make medicine and healthcare more personal. Or we try to change the legal and bureaucratic organization. You know, we add HIPAA in order to actually make medicine to protect the patient, make the patient more centered. And if you know anything about HIPAA, it hasn't necessarily had that effect. Or we throw money at the problem in order to try to make medicine more personal. And the problem is this, is that when you use the logic of the impersonal social forces and create interventions in order to change the impersonal dynamics, it doesn't work. You cannot draw from the impersonal social forces and create interventions in order to make medicine more personal. It's illogical, actually. But that is what's actually been going on for decades. So is there any solution? And I would, obviously, by our address, we're thinking spirituality and religion does have a potential. It does have a potential, but what often has been going on is that if we take our salt and pepper shakers of spirituality and religion, we try to shake it into healthcare, will that make a change? And it does not. What we've seen over the last, as Tracy and I have been working on this for the last 2 decades, it hasn't been. It's been, spirituality has been more like a caboose that's been attached to the high-speed train, and it's in itself has been often hijacked and used within the logic of the impersonal social forces. I could give lots of examples of that, but that's what we've been seeing. And what I would like to suggest to you is that there is a need for some kind of powerful engine that can attach to this impersonal social, this train that's going in the wrong direction. A power and an engine that could somehow slow it down or even potentially start to bring a change in that direction. And what I'd like to suggest to you, and it's a controversial suggestion, I know, is that spirituality and religion is actually the one and only social force that exists within the human psyche that has the power to correct and hold back in place these other impersonal social forces. It's actually the only thing that will work. And you think about how people, what motivates people. Money motivates people, power motivates people, knowledge motivates people, but there's another power. It's kind of the existential, spiritual, and religious that has a powerful effect on people. In our current system, these two things are totally separate. Medicine does not want it to have anything to do with spirituality and religion. but it is, I believe it's causing part of the reason why medicine hasn't been able to correct itself. So what would that mean? What would that look like to have spirituality and religion reintroduced? And we've been working with a lot of medical students and healthcare professionals in talking about this. And I would suggest to you that we need spiritual communities to come back into the world of medicine in order to help speak into it and to work with it in partnership. And I am a congregational Protestant pastor, and I'm going to speak out of my own tradition. I understand that probably most of you don't relate to my own tradition. And I hope it's okay that I speak from my tradition to whatever tradition that you may be coming from. And I'm not offering mine as better than yours. I'm just speaking out of what I know best. And out of the Christian tradition, there has been this long understanding that the care of the sick was actually to receive God's self in a very particular way. Because in the Christian New Testament, Jesus taught that when you receive one of these, he referred to the sick, when you receive a sick person, in my name, he said, you receive me. And Christians, as they began to reflect on this 1800 years ago, began to believe that Jesus' words were literal. And so when they went from the culture, the ancient Near East didn't want anything to do with the sick. It was just a family problem, and it wasn't a society problem. Strangers within the Christian tradition started to care for the sick and to believe that to receive the sick was to receive God himself into their own midst. And within the early spiritual communities, such as the Benedictines, they practiced this literally. These were the monks that were setting up monasteries, many of them whom were practicing Hippocratic medicine. And these monks, which were practicing medicine, the sick, would go to these monasteries because they wanted to get care and to receive Hippocratic medicine. And the monks would come out this is in the rule of St. Benedict, this is in the 5th century. The monks would come out as the patient was brought to the monastery, and the monks would get down, this is part of the rule of they would get down on their knees before the patient and get down on their foreheads and faces and bowing down to the patient, welcoming the patient into their house, and honoring the patient as if it was Jesus who had come there. Because they believe that if Jesus is God and Jesus has come to you, what do? You'd get down on your face if Jesus came to you right now, I think. And that's what they saw the sick patient, and they believed that sick patient was Jesus himself, to be received, to be loved, to be cared for. And I've said to people, what would you rather have? Caring for you or caring for your mother? Your doctor looking at the computer screen, asking your mother for the 3rd time what her date of birth was? Or the doctor down on their face, worshiping and welcoming? That's the tradition that has existed for 2,000 years, that produced hospitality and compassion. And within this imagination, the doctor-patient, the clinician-patient relationship is not just a human relationship, but it was a recognition that the patient was the suffering Christ who had come into the clinician's midst. God self suffered, and the patient is somehow connected mysteriously to the suffering God and was to be seen in this way, and that the clinician somehow represented the resurrected Christ who had conquered death, bringing healing powers. And that in this mystery relationship, the patient was to see and somehow welcome healing through the clinician coming from God as the healer and only the healer, and for the clinician to see the patient and to see God within the patient. That is not just a rehumanizing of medicine, it is divinizing medicine, and it's divinizing the sick, so that they're not just a number, they're not just a case, they're not somehow how you're going to make money. They are a way that you are going to engage the sacred who has come immediately into your midst. So where do we go from here? These are kind of big ideas. What do we do? What do you do for Vail Health as you might be working within it or wanting to help it in some way? I think Tracy and I want to say spirituality and religion are important. They're important. We know this within those who are very sick. We know this within those who are experiencing mental health issues. We know this, that it's also true with those who are dealing with depression and substance abuse issues. Spirituality and religion is an incredible power. And the healthcare system needs to partner with this in order to build back up the heart. And there's lots of examples of how this would work, but healthcare systems need to have chaplains. Are there any chaplains here today? Okay, bless you guys. Chaplains are incredibly important to be part of the system who are caring for the sick. But it's not just chaplains, it's engaging religious communities. I was looking on the web. I know there are a number of religious communities that are within the Vail Valley system. Those are communities that could be engaged. I know and have seen how religious communities are dealing with substance abuse issues, which is very difficult to treat. And there's not a lot of interventions other than spiritual interventions, which have proven to be somewhat powerful and effective, and it's the religious communities that can help with that. It's not about propping up one particular religion or spirituality. It's about gathering together all of these in partnership, working with doctors and nurses and the healthcare system and the hospitals in order to become this new kind of train that has the power to push up against this impersonal force that is dominating American medicine, and I assume it is or will become a powerful force here unless you deal with it and unless you invite in those kind of partners. And I'll stop there for time of questions and engagement.
Great. Are we sitting here?
All right. Dan, how did you do it? She can turn it on up in the book. Oh, okay. That's right. Yes. Please. And wait till we get the mic, though. If you speak loudly and clearly into the mic, I will not repeat the question, and if you mumble, I will. So.
First of all, thank you for coming all the way out here. I think it was a wonderful presentation that you did. Before I ask my question, I should reveal that I trained at Boston City during the AIDS crisis. I'm an OBGYN. We did perform abortions. So my question to you, I guess, is having trained in the era and delivered medicine in a very diverse community and seen a hospital practice it without technology. You went in and saw the patient, you took the notes, you got oral reports, and having recently lost a sister during COVID to cancer, who was pretty much that story, I fully saw that when you do it impersonally, and she died without the sort of encompassing of all the critical little things that if you go in, you can't go in and see a nurse during COVID with all the people that you would normally go with. And it became very impersonal. And her family could be that family where they fall through the cracks. So reflecting back to how it was during my training, and as you suggest, I think if I understood you, suggest inviting in the religious community, would it also be helpful to stop and ask ourselves, can we remove technology? Can people go back to taking notes on a pad, which we've proven in education, it's often better if the children sometimes write it and don't type it in. I think we've seen that research. How do we bring that back into our own lives would be one question. And the second would be, do we also train our nurses and doctors because they're the first person that patient is seeing? And for example, for abortion, if you're bringing in someone who may have very complicated beliefs, so with the model you're suggesting, are there also other ways that that used to work in the past that we could go back and look at? Was I clear in my question?
It was. There's a lot of great questions in there, so I'll try to. First off, I'm sorry. I'm just sorry to hear about your sister, and sadly, I mean, stories like Anthony's or your own sister's experience are fairly common, and how to begin. I mean, it's one of those things which can seem so overwhelming, you'd hardly know where to start. But I think that you're right, that in the training of people that are engaging with people who are sick and their families, one of the first places to start is training. And the training should include, you really shouldn't be looking at the computer the entire time that you're talking to a patient. I mean, something, really basic stuff about interacting with patients and families, getting to know them, asking them simple questions that help you to understand who they are as a person. So, for example, a very basic, thing that you can do as part of, we do social histories when you're first kind of doing an intake of a patient is, simply asking, of course you ask about, who's at home and, are they working, are they married, do they have children, et cetera. But also asking about their values, what are the things that are really meaningful to you? Do you have a faith or do you have a spirituality that's important to you? And finding ways of really beginning to understand that. So yes, I think it can be sometimes removing some of the, it's hard because our technology we rely on it so much. And it is a tool that can actually create more time, but it's recognizing where it's getting in the way of key elements of what it means to really care for patients well. And I think what you're naming as far as like trying to limit the degree to which technology is getting in the way of relationships is one key way to begin to roll back. And then another is really training people well to really engage patients and families well, to know them, to connect with them. And that really needs to begin in as part of training. I mean, I don't know what your experience was with your own training, but I didn't get that. That was not part of my training. In fact, that was one of the reasons why, early on in my training, I wasn't planning on doing research work in this area, but I would find that I was dealing with patients and families, and I was completely ill-equipped to really be able to connect with them well. And I was finding myself becoming more and more impersonal and dominated by the many times. I mean, I'm a radiation oncologist. I mean, I can't tell you how much technology I work with, but dominated by the technology, and it was taking me away from the original motivation of why I was doing medicine. And then speaking with Michael and seeing these ways in which one's spirituality is definitely part of how one is facing illness, and realizing how ill-equipped I was, and that motivating that. So clearly there needs to, a start is training, but there also needs to be further work that's done to really begin to understand how best to train individuals so that they can be people that can intervene and connect with patients well.
So part of our training, I was a key in school of medicine, and
Yeah.
was actually the AIDS coming on.
Yeah.
Came on DNR. It was a big era that the School of Medicine and School of Law worked together about ethics and how we did that. But we were pre-technology.
Yeah.
So
Yeah.
many of my colleagues have left medicine because it's become so impersonal and sort of driven out, because it wasn't how we were trained. And so experiencing it now with my family, you see that. So we're simplifying it. My colleagues and I, 'cause we say, like, the technology came in and it seemed to
Push out everything. Yeah.
the training, push that all out.
Yeah, no, I mean, I'll just maybe summarize briefly, since, I mean, you're just saying basically you were trained in a time where it was much more organic to be interacting with people because the technology was not in the way. And now all this technology has come and is completely in the way. And what do we do about that? I mean, it definitely needs to be addressed. And we have to work with it to some degree, where it's with us, it's here to stay, but it needs to have limits. And I think discerning that is a process that takes discernment. So for example, I mean, I remember seeing, it seems like the most obvious like finding from a study that you could imagine, but there was a study that looked at, the degree to which whether a patient and the physician interacted with a computer between them or with the computer to the side, and just like positioning, and how that influenced how the person being seen, the patient being seen, viewed the encounter. And you can imagine, of course, the findings were they felt much more connection just with the space. How the room was situated in such a way. And of course, it also caused the physician to interact differently, to not spend all their time, because the way that it was positioned was in such a way that there was more interaction with the patient. So anyways, even like space considerations are ones that need to be taken into account when considering things like technology.
And there's ways, I'm going to weigh in here too, 'cause I'm standing up on the stage, why not? I was seen by a doctor, I can't remember what I did, but it was within the last year. And the guy came in, and he looked me in the eye, and he talked to me. We were talking about just pragmatic stuff, but he talked to me. He probably gave me 7 or 8 minutes. And I've gotten so focused on this business about everybody on their damn computers, I was like, wow. I didn't have a hugely complex thing. Like I said, I don't know what it was. But, I was like, wow, that guy spent 7 or 8 minutes. So it's not that he's like falling hugely behind on his schedule, but he had activated this sort of, if we think about spirituality at base, as one of its things is being this sort of profound human connection.
Yeah.
We were talking about this while we were hiking yesterday, that this is what machines don't do, that we need and crave so much. There are ways, just tactically. I work with the hospital chaplains down at Emory, which is this huge program that's developed in spiritual health, and we've done a study showing that if you train the chaplains, or the spiritual health clinicians, as we call them, in something called compassion-centered spiritual care, one of the things that the practice does is before they go in and see the patient, they just take a few minutes, just a couple minutes, center themselves, think about how am I feeling, and then sort of to your divinization thing, right? How can I honor this patient? I'm going to clear out, I got all this other stuff going on, blah, 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 but okay, I'm going to clear it out now, and I'm going to focus. And we've actually been recording, the audio recordings of interactions of chaplains who did and did not get that training. And the ones who got the training, the people come out with the patients, when they're over, if you ask the patient, they're less depressed. So just these are tractable things that can be done that they don't save the whole world, but they tap into, Michael, what you were talking about, this idea of the divinization of medicine is so fascinating to me, that sometimes the way to get to, 1 square is to hop up 3, and so that idea of really taking a moment and thinking about, oh my God, this is human being's a spiritual entity that's in front of me. I've never seen anybody scientifically study it. That's me, but it's kind of interesting because I think it's a powerful idea. Other questions? Yes.
Hello, thank you so much. This was a really interesting topic. So my name is Olivia, and I work for CVS Health, supporting our Oak Street business, and it's focused on senior-focused primary care. And so, this was a really interesting topic for a lot of reasons, but one of the things about Oak Street is there's a lot of it's a community center. They do social events, programming, and all those types of things. So when you were talking about, I think, use the term communities of meaning, and kind of creating that spiritual communities of meaning, and then how we can have the providers or the care team help support those patients for their end-of-life care needs or whatever it is from a spiritual perspective. So I'm just curious if you could elaborate a little bit more on kind of, you talked on education and training. Are there screening protocols or any resources at either the national or local level to help partner with spiritual communities and resources to support those patients?
So I love that it's its own community, and that's one of the reasons why I use that term is I think it's important to have to realize that yes, it could take spiritual communities can take many forms, and I think in a way that you have to cultivate that within, and it sounds like that's what's indeed happening within this elder community, that there's a cultivation of that, of those relationships, of connection, of so I think one thing that can happen is within those communities is cultivating sort of a sense of connection, of spirituality, so that within it, it can provide for those needs of that community. As far as connecting with faith communities, there have been a number of, so there have been some public health endeavors where they've actually begun to do work with various faith communities, usually on very targeted sorts of interventions, like I mentioned screening earlier. So there's been, work on things like breast cancer screening or other forms of screening or education, blood pressure screenings, et cetera, where they actually go into communities and make those connections. So some of them on the public health level, those have been explored. There's a lot, I think, more work that needs to be done, but certainly some research work that shows these to be generally very successful ways, particularly for accessing communities where a spiritual community is really kind of a primary locus of where they might gather, et cetera. I think that other ways of forming those connections would be by having kind of ambassadors that understand the language of both go between those communities and your healthcare facility. So chaplains would be a number one example, and part of their role is indeed to be, connecting with the faith community. So, I gave in the example of Anthony that, he'd been seen by a chaplain, and in my understanding is that there was no connection, and often there isn't necessarily connection between the chaplain and the faith community. But where that could be really uplifted, it's oftentimes a resource issue for chaplains. So that they can be playing more of that role of connecting with faith communities, so that spiritual care isn't just happening within the healthcare system. It's it's actually being connected out to the communities that surround that person, so they're aware that this person is in the hospital now and going to have ongoing needs, et cetera. So having those sorts of ambassadors, it doesn't. I think chaplains are a main one. It doesn't have to be only chaplains. To create those connection points with communities. But I think it's sort of like there's a public health avenue that one could forge those connections. And then there's also, having people from within the health system that actually reach out to those communities and offer those points of connection.
Yes, a couple questions here. Why don't we take the gentleman first, and then okay.
Sorry, can you raise your hand again?
And for those that need to leave, thanks for coming. Yes, sir.
Again, thank you for a very interesting, and your experience and your research is very valuable. I'd like to switch it a little bit from the impersonal and the personal. My wife and I have lived the majority of our life in Asia. So we've got to know their sort of religions or philosophies of life. And it's very evident to us, living such a long time, and we're still there in Asia. The emphasis there is on family and on elders, and that compassion. And I think most of the Asian countries, as far as caregivers, is just exceptional. Yeah. And we rely on that where we are, and we see other communities there. And I really don't see it here. Now, we come back for 4 or 5 months a year, and we engage with Vail Health and others, and they're taking steps, but I think we got to get back to the basics of family and spiritual or religion. And it's just an observation that we have in comparison.
You want to speak to that?
Yeah, I agree. I mean, there are all these cultural forces that have created this situation. People, moving all over the country, so families aren't together. Parents live in one place, their children live in a different place. And the caregiving is, and then we live in a culture that values youth, not being old. Being old, you're over the hill. Whereas in other cultures, being old this is a treasure. African cultures, certain Asian, to be old, you are honored, and everyone gathers around you. So not so. So we're dealing with some of these effects of our culture that, you know, is arguably not so healthy.
There was another question up there. Yes, go ahead.
Thank you this is such a fascinating topic to me. I look at it like there is a lot of layers to it, right? When I talk to physicians and nurses, a lot of times they say, we don't have time. We don't have time with our patients, and if we get in there, you know, we just have to ask the technical questions and then leave. And then a lot of nurses are scared that if they give too much, they're gonna be burnout. So there's that compassion fatigue. When actually now the recent studies show that actually by opening our heart to people, you don't burn out. And that's how people get better. So I think it's a combination of giving, you know, our physicians, our nurses more time, and also training about how to work and see people with their pain. Because I think what happens is as we go in and you start working with people, especially around death, all of your stuff comes up as a provider. And then also being grounded enough to see people in their pain, in their suffering. And that helps give them permission to then be able to express their pain. And so this is, again, such an important topic. I think this is how people can die at peace. And I think leveraging certainly the religious communities for sure, but I also think that there's people in our community that can do that work too, to come in, whether it's our therapists, our counselors, that have had that training, because it's just allowing people to see people behind the veil, to see people in their humanity and all of it. And so I think leveraging, again, spiritual communities, but also other people that can do that work and be able to see people in that profound way. So it's more of a comment, but I thank you for this work, because this is how people get better.
I agree. I mean, in fact, Chuck's comment made me think of this, of the whole idea of kind of centering yourself before going into the room. Like, I think that when we care for people, like having practices, our own practices, that cultivate our own sort of sense of ourselves and centering and even our own spirituality, and have that integrated with how we provide care are really key. Like what Chuck raised made me think of something that Michael often will teach to the trainees, which is, you know, we all have to wash our hands, you know, now with the Purell or whatever, and it gives you that few seconds to do that, to center yourself in whatever ways that are meaningful for you, but just to be ready to go into the room to care for someone, to see them as you know, in their humanity, and to be present for them. Because there's a way that it definitely is the case that when you embrace and see someone in that way, that you are yourself. You are yourself embraced. You're cultivating your own spirituality. And when that's neglected, it goes the same way. You're neglecting it, and it's a harm to the patient you're caring for, or the person, the family. But then it's also, in a strange way, it's also a harm, and it's a dehumanization of yourself at the same time. And so uplifting that, and I agree, it can be a variety of people that can do that, and then providing training that allows for that cultivation, I think, also is key.
And yeah, that's what he's saying. I did work with two nurses, and where they pause, I had them pause before they went in the room, so it's so interesting. Because they felt their heart rate was raising when they were dealing with a patient that was being a little erratic. And they'd get really nervous themselves, and when they pause, take a second, and then enter the room, they said they could see that patient with compassion, and then they watched as that aggravated patient that never felt like they were being seen start calming down.
Yeah.
And then the whole room changed. So yeah, I think that just those simple things can make a huge difference.
That's a wonderful, that's a really amazing story. I work with a lot of I kind of have a lot of spiritual conversations with medical students and residents, and have done research in the past, and the experience, most of it are, people in their 20s. A lot of them have never seen suffering. They've gone into medicine, especially become doctors, because it's a wonderful profession. There's a lot of prestige and potentially money. They haven't seen suffering. And then you get exposed to watching someone die in front of you, to seeing people hear just terrible diagnoses and so on. And what I've seen with the medical students is it's a crushing kind of experience to see the suffering in someone else, and then to realize that they within themselves don't have the resources to understand it or to know what to do with it, because there is this transference in which all of this pain within you arises. And that's where the spirituality of the caregiver becomes really important, and the formation of the caregiver. And what we've seen in a lot of medical students is they practice, a lot of them will practice escapism of various kinds of coping. They party, they'll drink, they'll do things to forget, because they don't know what to do with all of this death and dying and suffering. And that's where spirituality really, and we've seen a lot of medical students, they become more religious. They'll go back to the traditions that they were raised in, and they realize there's resources. It could be Buddhism, it could be Christianity, and so Judaism and so on. They'll go back to the traditions that they were raised in, saying, okay, now I have questions. And those traditions, many of them, have actually significant wisdom to speak, to help people understand, as well as to practice. And so that's part of what we're kind of arguing for, is that we need clinicians who are going back to their traditions, or opening up to discover a new tradition, that they can draw the resources, because that suffering it's a devouring energy that no one knows what to do with, unless you are taught and you learn to practice to be with it, and to be human, and to be human with the person that you're with. And so we're in a culture that's being lost, and I think that's where there needs to be a lot of invitation to go back or to re-engage these things.
You have the mic. Somebody's got a mic. There's a question up. Oh, let's do this, and then we'll catch one upstairs.
This slide is very interesting to me, in the sense that if you put it in the terms of Alcoholics Anonymous, the hospitality and compassion is the major portion of that program.
Yeah.
You're only asked to give $1. That's the business end as a contribution. There's no science or technology other than a coffee machine and possibly a ventilator during rehab. There's no legal or bureaucratic, that's forbidden. But there's a tremendous amount of help and hospitality and compassion. And it just seems to me that we could engender more of that in the medical system. Understand it's a different circumstance for diseases of the body, but that the business of welcoming a new person into the AA rooms, there's a feeling of welcoming, of understanding, of compassion, and somehow if that model could be engendered in the medical arena, it might cause some stronger sense of hospitality and compassion in the process.
Yeah. No, I
Wonderful
love
point.
that. Yeah, I love that.
There was one upstairs, too.
Tracy and Michael, thank you so much. One comment and then just follow up kind of what Dick was just saying. I think I'd add underneath market and business the food industry. And under science and technology, I think the biggest challenge is the siloization of healthcare.
Yeah.
Everything's a specialty now, which has further reduced time with patients. But I would challenge you and this whole audience on the conversation we've had tonight. It's not a provider clinician problem. It's not a training problem. It's an administrative of healthcare problem. It's the administrators of healthcare organizations It's the boards of hospitals and these giant conglomerates. It's not the providers. There's no provider in the country that wants to see 20 or 30 patients a day.
Yeah.
There's no provider that wants to take every night and weekend doing charting and using technology. There's no provider that would rather not see their patient in person. But we've built a healthcare system that demands that they do that. And that's why they're burning out. That's why they're leaving. And that's why they're failing at their job. And that's why in America, we have the worst health outcomes of any developed country in the world, but yet spend twice as much as the second place worst. So I think we've got to attack the leaders of healthcare industry, and they can push back on these other three market forces to bring the change if they came together and worked as one.
I think
Thank you.
it's an excellent point. It needs to start. I mean, so much of it comes from that very top. But then how you influence, I mean, what are they answering to? They're answering to financial forces, bureaucratic forces. You know, how do you intervene on that? You know, how do you give, how do you get hospitality and compassion into that boardroom? You know, that becomes central. That becomes the central message, and everything else serves that. I mean, how to make that change is something that needs many, I think, hearts ready to put that at the center that are at the top.
I agree with what was just said on that, and what I've observed is that the communities are finding their own solution around the bureaucratic or
Yeah.
the American culture of making money. And the hospital that I worked at, they recognized that all the families had moved from where they were born. So you had all these mothers giving birth, and they didn't have support to breastfeed. And what they realized is it was very simple. If they created a lactation program to be able to support these young mothers breastfeeding, the fallout was that these women had support as they raised the children on their own. And it also led to the very basic thing of if the mother could regulate herself and do the deep breathing, then when she took her baby that was crying and took to breast, then she would quiet herself down. She wouldn't focus but worry about the baby, just quiet yourself. Same thing, like you grab the oxygen, you do you first, then the kid. Then they would notice, oh, I'm calm, now my baby's gonna be calm. And the babies would learn how to regulate themselves. So by having these lactation, a very simple thing, opening these centers, being able to, as the mothers were being discharged, following up, helping them with all of this, it was also helping them, how do you regulate yourself as a mother in a very chaotic environment? You're trying to go back to work, you have all these pressures, breastfeed or whatever. And so having these people that were there to guide them when their mothers or sisters may not be around, and as they learned how to regulate themselves, they could then pass this on to their children, so that they were having children who were like, oh, okay, this is my mother's just regulated herself, now I'm being regulated. How do I do it? And so I think it speaks to that there's ways we as a community can come together and support at the most simplest level the very basic, the woman in front of me was just saying, compassion, opening up and just holding everyone and with the most basic. And it doesn't take that much money. It's just about caring and being present.
Yep, absolutely. Please. Maybe we're doing more, and then we'll call it a night.
I wanted to say thank you, Tracy. Appreciate you being here. I'm a retired nurse practitioner. My name is Harold, and this is my husband, Jerry, and he's a hospital chaplain volunteer, and we're both hospice volunteers. And we had a real active hospice here in our own valley about 20 years ago. And the hospital at that time, Vail Health, it was called Vail Hospital then, supported that financially and with space for offices and that kind of thing. And we really appreciated that. But at some point, the administration made the decision not to support hospice anymore. And so a hospice from a nearby community in Carbondale and Glenwood Springs now, called Hospice of the Valley, is covering this area. And in the process, we lost our volunteer group here because they didn't keep that going. And we're trying to get that going again. We have people interested in volunteering. And if you think about what heart means, that's really a hospice volunteer, because there's no money, there's no prestige. It's wanting to help people as they near the end of their lives. And I think that that's a good resource for this community, and it needs support from the hospital again. I don't know how to make that happen. Maybe go to the board. I don't know if you have suggestions. But it's a really important aspect and option for people. But one problem we have here, and I think this is true for hospices throughout the country, is that doctors do not tend to refer people for hospice until the last few days of their lives, which is really a shame, because there's all kinds of support systems for people that meet those needs you were talking about. There's chaplains, there's social workers, there's nurses and doctors that can help with pain and care, and there's all kinds of things that can be done. There's family teaching and help and care and love that can go to those families that are facing this and that patient, that can really work if they get referred in a timely manner, when they can have that happen. So I just want to encourage you all to know we are here in the Valley as a hospice of the Valley, and that we would love to have you tell people about it and to utilize it more. So thank you.
Yeah.
Thank you all very much for taking the time this evening to spend some time and learning about spirituality and healthcare. Thank you, Tracy. Thank you for coming and being here as well, and sharing this good information. And we'll figure out, Chuck, how do we study this and how do we do some of this locally? So thank you.
Thank
you, everybody.
Thank you.